for joining. It looks like we have quite a few attendees, which is just fantastic. 19 participants, and people will keep coming in, I'm sure. I think this topic is very relevant for our nephrology grand rounds today in Ottawa. We have a lot of interest in hypertension here in Ottawa, and we have a number of people in our division who have developed expertise in this area, have a large hypertension practice, and have both national and international recognition in the area. So I think our guest speaker today is perfectly suited to talk to this audience. And I'm very happy to introduce Roberto, Dr. Pecoits-Filho, who is going to be speaking to us about the KDIGO guidelines. Now, I'd like to give a little bit of an introduction for him. Now, he's a senior research scientist at Arbor Research Collaborative for Health in Michigan, USA. He's a full professor of medicine at the Pontifical Catholic University of Paraná in Brazil. He's current chair of the Education Committee for the International Society of Nephrology. And in his clinical life, he has broad interest in internal medicine and nephrology. He was the chief of the Department of Internal Medicine between 2010 and 2016, and the director of the residency program in nephrology from 2013 to 2016. He's the principal investigator for the CKD, which is the Dialysis Outcomes and Practice Patterns, focusing on CKD study, a multinational study on practice patterns and outcomes. And he's a scientific leader for clinical trials in the Americas with the George Clinical Center in Australia. He received his MD in training in internal medicine and nephrology in Brazil. Then he did the university research fellowship in nephrology, at the University of Missouri, Columbia, and a PhD from the University of Sao Paulo. He's a visiting scholar for extended periods at the Karolinska Institute in Sweden and the George Institute in Australia. And he's participated in multiple studies as a principal investigator, a regional leader, steering committees. He's very well published with over 300 publications. And he served as a member of the executive committee of the International Society of Nephrology, the Song Initiative, and KDIGO. So with that, Roberto, please take it away. Thank you.
Well, thanks so much, Manish, for this kind introduction. And it is to me a great pleasure to be to join you today with the with the background information that you provided. I am sure that this group is very well suited for the discussion that we will have at the end. And I hope you guys enjoy the presentation of this clinical guidelines that were recently published by KDIGO. I think most of you know KDIGO. It's been a pleasure for me to be working with that organization for many years and to have participated as a member of their steering committee for the development of this practice guidelines. I hope that the day for you guys across the border in Canada is as nice as it is today here in Michigan. It's here it's sunny, it's still a bit chilly, but a very nice way of a nice setting for this discussion that we're going to have today. So great pleasure and honor to be here. So the story of the blood pressure guidelines in chronic kidney disease started in 2012. So KDIGO has initiated this almost 10 years ago with the evidence review process and the publication of the guidelines based on what was at that point the current information that guided the recommendations that were published almost 10 years ago. And KDIGO has an interesting model for monitoring how the information evolves and how eventually revisions are necessary. And so as a follow-up to that process that has been implemented in recent years, in September of 2017, we had a meeting in Edinburgh, Scotland. And during that meeting, as usual, KDIGO brings together people interested in the field, publishing in the area of blood pressure and chronic kidney disease. I felt that my participation there was more not as a hypertension specialist, but a CKD expert with participation in different trials, and also maybe most importantly, being the principal investigator for an observational study of variations in clinical practice and clinical outcomes that was mentioned by Manish in the beginning of this session today. And during that meeting, we had a discussion about several topics. I remember that I participated as a co-chair of the working group that was dedicated to the management of hypertension and CKD in elderly and individuals with previous stroke. And the main intention of meetings like this, which is not a guideline development meeting, is just a touch base to see how the current information is, and critically assess the need for revisions in the published guidelines. First of all, we had a great discussion, and it became clear to the group that there was enough new information to trigger the process of development of a revision of the guidelines in 2019. So this is the first step, was just to form the work group. So this is the group that started working in 2019 in the development of the guidelines based on the output from the controversies meeting published in that I described in the previous slide. You'll probably see here many familiar faces, including this group that is described here in this slide that is part of the published paper. So the effort was led by Alfred Chung and Johannes Mann, and the working group is described here. And just calling the attention to the presence of Greg Knoll, who is actually from Ottawa. He might actually be in the call today. And Greg, if you were there, please jump in to contribute to the presentation, and looking forward to discussing that with you at the end. So the characteristics of this group, and this is typical KDIGO model for forming working groups to develop guidelines. First of all, there is worldwide representation. Second, just to keep the memory of the previous work, they usually have about half of people in the work group who were working group members of the previous guideline. And more and more, and this is something that has been very interesting in the process of guideline development with KDIGO, they bring to the core of the discussion the evidence review team. So this is a timeline for the development of these guidelines that I'm going to be discussing with you today. So as I mentioned, in 2017, the group met in Scotland, concluded that there was a need for a revision. The working group was appointed at the beginning of 2018, and then we started working. As usual, there is the scope of work is submitted to public review and stay there for a couple of months, right in the beginning. And then the evidence review group was contracted and started the work by mid-2018. The evidence review process continued until 2020. And then we had one meeting. So only one face-to-face meeting was occurred for this group, which is unusual. Usually we meet more than once. I guess because of the timeline here in the, especially the special situation that we all lived due to COVID, and towards the end of the process, we actually couldn't meet again. So lots of calls and meetings throughout the year 2019 and 2020 that culminated with the publication just a few weeks ago. So just a few points, again, as a background for you to understand, some of the rationale and models used to develop this practice guideline. First of all, it was clear to the group that it would be very hard to include dialysis patients in the discussion. I mean, it's so different. The concepts are difficult to apply in a generalized fashion. There's much less data available in terms of RCTs in dialysis patients. So really the focus was on non-dialysis patients. There was a discussion and then a decision to include children and also transplant patients, which was included in the evidence review and the recommendations. Also, there was a feeling that a lot of focus should be given to BP measurement techniques. And also something that I think it was very nice was to really address interventions related to lifestyle targets and pharmacotherapy, but really focusing on RCT data, which actually provides the final guidelines with a very robust recommendation. Also something to remind everybody that there were areas that were not covered because they were published elsewhere by KDIGO or others, for instance, lipids. So there is a specific lipid lowering recommendation that KDIGO published early in the 2000s. And just because of the perception that there was not sufficient data on risks and benefits on blood pressure, things like weight loss or reduction in alcohol consumption and emerging and pipeline therapies were not included, just to keep the focus on the rigorous data analysis based on RCTs. So from a high level, what was actually perceived by the group that met in Scotland that generated or that triggered the need for a revision in guidelines. So there are 4 points that I think were important in that decision. One is, again, a lot of new data on techniques of BP measurement. Second, and I think this is very important, and as you would see, and probably we would like to discuss later on, there's a lot of weight in the new data brought by Sprint and SprintMind, including the CKD specific publications. Just as a reminder, Sprint actually included by design about 30% of patients with CKD, and that allowed for a robust analysis of the subgroup. And also the Accord group has done some additional work after 2012, and that provided additional information that changed the perception of what needed to be recommended. And with all of this, there were some important meta-analysis work done in the CKD population that provides new information that was relevant to review. Okay, so the evidence review team was chosen back in 2019, and the group chosen was the Cochrane Kidney Transplant Evidence Review Team. So they are based in Sydney, in Australia. And they started working based on first the the existing PICO questions, but then new questions were developed as a starting point by the work group. And then the clinical and important outcomes were identified right in the beginning, and they are described in here. So this is a summary. This is from the KI paper, and it reflects the literature search and evidence review. Again, this was done from the end of 2018 all the way until April 2020. And this graph summarizes all the work that was included. So quite a lot of stuff for the evidence review team to work on. KDIGO adopts the grading recommendations described here. So, you know, you're all very familiar with this, and this has been the focus of the group, of the work group, has been looking at the evidence provided by the evidence review team to really classify the recommendations according to this methodology. A few things that we also really brought to the center of our discussions was particularly things like patient values and preferences. I think that was something else that changed a lot during the last few years, is just to incorporate patient preferences, patient values into what we are recommending, or taking that into account when making the recommendations. And also, since KDIGO is a global organization and intends to have the implementation of its guidelines across the globe, other things were, considered, like resources, financial impact of the recommendation. And you see, at the end of my presentation, I have a few comments about that. All right, so this is the final thing that I wanted to discuss with you in terms of background before I go into the recommendation, because this is something that, to me, as a member of the group, represented perhaps the most innovative approach to guideline development. And this is the introduction and the use of Magic app, making grade the irresistible choice. That's the way that they define themselves. As a helping tool to the process of collecting and revising the work of the evidence review team real time and during the meetings. So I'm going to describe just high level what this is. So it is a guideline software based in Europe. It's a small company, and actually KDIGO decided, and this was actually recommended by the KDIGO leadership, to pilot this platform with some potential advantages. First of all, during the process of reviewing the evidence, the group had direct access while making recommendations. So I think that in the process of discussing the evidence, Magic app provided a nice platform for us to look at individual data and understand better the messages behind the evidence review process. Also, there was a feeling that this increased the transparency of the process, since this is so nicely displayed. And then I guess this is more in the implementation phase. It becomes a platform for digital publishing of the recommendation and the evidence review process, and creates, I think this might be the most important thing, because I think this has important implications in the process of reviewing guidelines once new information comes on board. Because it is easy, once the information is inserted into the software, to just add what is published in the future, and then you almost have like a living guideline, making it easier to update the process of recommendations. And the final thing, and I'm going to show you an example later, is that it also allows for the generation of patient decision tools. Couple of examples. So this comes from the Magic app. So imagine if you are sitting in a guideline development group discussion in a meeting or in a teleconference, and then while discussing, you have in front of you the screen from the Magic app in front of you. So you see here that you can, all of us that were working in that group, we had access with the password. We had access to the raw information in the software. So we could log in offline and look at individual pages like this one. For instance, this is the specific analysis of the intervention. Low blood pressure target lower than 120, compared to with the specific question of the comparison to standard blood pressure target. And then you can see here at the bottom of the slide the specific information for the overall information grouped by the software after the input from the evidence review team. So you can see, details of the studies. You can see the absolute effect estimates, and then the software provides also a certainty of the evidence ranking and a plain text summary. So as a guideline developer, it really facilitates the process because you can see the summary of the findings. And here, if you click on individual studies, you can actually go to the source of the information, and actually you can see the overall numbers. For instance, the number of participants for that particular intervention with a certain outcome, the number of studies that base that there's the basis of the data. And then at the bottom of the page here, you can see, that, for instance, for this particular question, all the data that comes out of the evidence review process is actually based on 2 studies. You can see the characteristics of the study, the number of participants. I mean, I know that we are familiar with the big studies, but for some things, it was really nice to be able to access, where the evidence comes from during the process of discussing the recommendation. So I think first of all, the process was really optimized. Second of all, it was a process that was that provided much more transparency and much more participation of the members of the working group, not as people involved in the creation of the evidence review process, but really looking at the characteristics of the evidence and then providing with that in front of you in the group, providing the recommendations. So that's a bit of the background information and process that I wanted to, just use this first part of my talk to make it transparent to you and bring that insider view of the process to the initial part of the discussion here today. And I wanted to just, before I move to the actual recommendation, which is the second part of my talk, I just wanted to stop here and ask if you have some initial thoughts or questions or comments about the process itself. So I'll stop here, and I'm happy to hear your initial reaction to that.
So in mid-talk pause for questions, do we have any from any of the listeners? And maybe if as people think of a question or chime in, I can maybe start because that is very interesting. I have to say, I was writing it down as I heard you go through it, and it's amazing now that there have been, of course, there's systematic review software, but this is taking things to now the next level.
Yeah.
And if we're all working virtually and online, people can essentially be looking at this data while they're doing it. So as you mentioned some of this about creating a living document using this technology, has the group even, it's such a rapidly evolving field with new studies constantly coming out. Yeah. Since the publication, have you used this software, the Magic app, now to even go and see if anything's changing, or have new studies been added actively to this?
Not yet, Manish. In the area of blood pressure, especially the recommendations that came up with this, I think there was nothing really new enough to be inserted here. But any moment, if something comes up, this could be done using this tool. I was just thinking as you were describing, if this was a CKD, progression of CKD guideline, I think this would be, for us nephrologists, it'll be so clear that this will be used in the update process, right? I was thinking about the other guideline that was published last year, the diabetes management of diabetes guidelines in CKD. That one, from December to now, you have several new things that were published already, and that will need a change in recommendations. So I think I don't think that there was anything really new in the process between late December or late 2020 and now that required, but it's ready to do it if something happens. And I think this is really, as you mentioned, I think this is really revolutionary, because the process that we use in here took almost 3 years. 3 years is way too much to develop, or even to revise it even longer. So I think something like this is really necessary in this world of guideline development.
Yeah, I could see it. We are having similar problems with the Canadian guidelines, is that things are taking too long. This is a terrific idea on how to move things forward. We have 2 questions from the group. I'll just put them maybe both forward to you. Mm-hmm. One is from Dr. Davis, who's asking, do we have access to the data in this format? And the second is there any idea about cost to use Magic app and to maintain?
Yeah, well, first of all, the KDIGO is analyzing the strategy to provide access to this form of data. At the moment, this is not available, other than the reports that can be generated by the software. So, for instance, there's some patient related information that KDIGO has made available, but not to the raw data at the moment. This might be something that KDIGO decides to do it later on, but at the moment is only reports that are extracted from the software and not the software itself. So during the process, all members of the working group had passwords to access the full information. But I think the decision what will be used, it's on KDIGO's hands now to decide. The second thing about cost, unfortunately, David, I will not be able to provide you with that information. I didn't have access to that. But I can tell you that there was, it was from KDIGO's evaluation, at least the initial agreement was actually, cost effective in a way, consider the benefits.
Fantastic. Thank you.
Okay. All right. So let's move. And for the second part of my presentation, in the next 20 minutes, I'm going to be talking about the recommendations themselves. So the final publication is divided into 5 chapters. The first one will be on blood pressure measurement, then a chapter on lifestyle interventions, then blood pressure management in CKD, and there will be a division between diabetes and non-diabetes patients. And then there are two additional chapters, one on transplant patients and another on children, that I will not cover today, other than give you just a very high level recommendations that came out from those two chapters. So let's start with blood pressure measurement. So this is work of two members of the working group had to focus on this, and this is the first recommendation that came out of the guideline. So we recommend standardized office blood pressure measurements in preference to routine office blood pressure measurements for the management of high blood pressure in adults. Good level of evidence and an interesting recommendation here. This is a figure from the paper, and I'm going to go over all of the recommended methodology for blood pressure measurements. But as you can see here, and this is very different from the previous KDIGO guideline recommendations, a lot of emphasis on the methods used for blood pressure measurements with very specific recommendations that are summarized in this figure. You will notice that in terms of the device, there was a lot of discussion about this, of what kind of device would be recommended, an oscillometric or a manual, and there will be a specific recommendation later on, but as you can see here, the group didn't position itself to one or the other. It's more of a focus on standardization. So again, just a summary of what's in the picture. In the previous slide, a lot of focus on proper preparations. And I'll focus here on providing you some of the views of the team in terms of advantages and disadvantages. One of the advantages is that, it was, this is really based on what was employed in large RCTs. And with that, the method described minimizes misclassification and overtreatment or undertreatment of hypertension. And I think this is a major advantage of this new recommendation. Obviously, the standardized BP measurements require staff training, retraining, and require more time of patients, providers, and staff. And this should be taken into consideration. But the group felt that the advantages are much bigger than the disadvantages for the standardization. So you see that other than the recommendations themselves, there is a lot of practice points that were introduced when the group felt that there were messages that could be useful to clinicians that should be provided, but there was not, a formal evidence review process possible for those specific points. But again, usual practice points that could be useful in clinical practice. So first one is the practice point that an oscillometric BP device might be preferable to a manual device. Now the group felt that it was important to say that the standardizations emphasize adequate preparations for the measurement, not for the type of equipment. Second practice point is that AOBP, either in the office, either attended or unattended, might be the preferred method of the standardized office blood pressure that is recommended by the guideline. And that oscillometric devices can be used to measure patients also with atrial fibrillation. So the use of this recommendation, the implementation of this recommendation may increase the likelihood of compliance to proper protocols. It removes sources of inaccuracies compared to the manual measurements, and may reduce also the white coat effect. And also free staff to complete other work, which is always a challenge in busy clinical settings. Importantly, this is all based on what was used in prior RCTs, as I commented before. Okay, so this is the out of office a figure that also comes from the patient, from the paper that is summarizes the recommendation 1.2, and that is the suggestion that out of office BP measurements, both with home monitoring or ambulatory BP monitoring, should be used to complement the office readings in the management, and that might allow for, you know, a optimization of the process, both for patients not taking medications in the left, and also patients taking already antihypertensive medications, with the potential advantages summarizes in the different squares of the figure. All right, so that was what the guidelines say about the measurement method, and now I'm gonna move to the recommendations regarding lifestyle interventions. So again, here, guys, there was a major evolution in terms of the way that this is recommended and the way that the evidence review team captured the information. So the robustness of the recommendations and the way that they're written in the guidelines are pretty different from the previous guidelines in 2012. First of all, in terms of sodium, there's been an increasing perception that sodium restriction is super important in patients with CKD, particularly in CKD. So there is a target for sodium intake of less than 2 grams per day for those patients. And with the 2 practice points highlighted, one is that this is not for all. There's some patients with CKD with sodium wasting nephropathies that obviously should not be restricted in sodium intake. And a particular recommendation regarding the DASH type diets, and also the use of salt substitutes, which are rich in potassium. And in patients, particularly with patients with more advanced CKD, there might be a higher risk for hyperkalemia, and those patients should be monitored carefully. I have to confess that, the target, or the exact point that hyperkalemia becomes a problem for potassium-rich diets, it's not very clear. But perhaps more clear is the fact that, patients with advanced kidney disease, like patients with GFR lower than 30, might be really a higher risk. But I think there's a gray area when the GFR is between 45 and 60, in which probably the hyperkalemic events will be very rare, even in potassium-enriched diets and supplements. So the other recommendation regarding to lifestyle is around physical activity, not only with the recommendation of undertaking activities, but also defining a target of 150 minutes per week, obviously with some flexibility when it comes to tolerance and the profile of the patients. There are practice points related to this too. They are more related to the considerations of physical limitations, comorbidities, risks that should be taken into account when making the decision about the physical activity interventions for individual patients. And then again, like in many other parts of the guidelines, flexibility and individualization is really an important point to highlight. Okay, so this is perhaps one of the most difficult parts of the guideline, and something that might have received more criticism and represents concerns in terms of implementation, and that's the target recommendation. So first of all, based on the RCTs, the first decision was to recommend a systolic and a diastolic target, or just systolic. And the group felt that, based on the updated literature review and evidence review, that the most of the studies were actually targeting a systolic of 120 as the primary outcome. And therefore, the group felt that a target of a systolic lower than 120 should be recommended, heavily based on the sprint new information, including in the CKD population. So the recommendation ended up being weak after all the revisions, because there is much less certainty of the benefits and harms in those particular clinical scenarios that are summarized here, namely the patients with the lower GFR, patients with diabetes that were obviously not included in the big new study, which is SPRINT. Also a gray area in this systolic between 120 and 129, and other things like patients with more comorbidity, older patients, more frail, and other aspects. So ends up that the ranking of the evidence basing this recommendation is not really perfect, but the group felt that we should clearly state a target based on the systolic of lower than 120. This is the rationale. And I mean, it's, as I said, mainly based on SPRINT. And SPRINT shows not really a benefit in progression of kidney disease, but mainly a reduction in cardiovascular risk. It's important to state. And also, we now understand that cardiovascular disease is sometimes a more important outcome than ESKD, and more frequent too in those patients. There's also data from ACCORD that supported that, not only SPRINT, and especially the revised meta-analysis were pretty convincing. Now bringing another example from the MAGIC app application, this is patient tools that could be generated more related to the, this primary recommendation of the target of blood pressure. So if you are a patient and you wanted to have a feeling for, among 1,000 patients like you, what is the benefit from having a blood pressure reduced to lower than 120. And you can see here what the evidence brings to patient-friendly information is 14 fewer events of all-cause mortality, nine fewer events of cardiovascular mortality, and so on. And if you are a patient and you wanted to have an idea about how visually that looks like, those are 1,000 patients like you, and here is in red the reduction of all-cause mortality events that you would expect for joining that recommendation. All right. I'm going to skip that for the sake of time and go for the final recommendation that is not related to target, but more related to the use of RAS inhibition in the management of blood pressure and CKD. So there was some subtle revision of the recommendations compared to the previous one, which already recommended the preferential use of ACEs and ARBs for this population. And it's more like granular, so people would understand, when would be preferable and what groups are the ones with the most benefit. So if you take, for instance, recommendation 1 here, in patients without diabetes, with CKD G1 to 4, the group with higher albuminuria without diabetes is really the one where the use of ACEs and ARBs are more beneficial. Also, a group of patients without diabetes, but with less level of confidence and in not recommending but suggesting patients with A2 without diabetes should be also using a ACE and ARB as a preferred agent. Now, for patients with diabetes, from G1 to G4, A2 and 3 have a high level of confidence that ACEs and ARBs should be recommended. And some practice points are attached to that. Obviously, it is reasonable, but there's no real evidence to support that even in patients without albuminuria might benefit from the use of ACEs and ARBs. This is highly controversial. And the concerns about side effects of these drugs are brought into the attention of the community in the guidelines with the recommendations of monitoring of both serum creatinine, changes in blood pressure, and serum potassium that should be monitored. And here, a specific recommendation that the time for monitoring after introduction of those agents should be between 2 and 4 weeks of initiation. In terms of discontinuation, there's also some practical recommendations related to that, and that is that eternal questions of how permissive you should be looking at the changes in serum creatinine before you discontinue the RASI treatment. And current recommendation included in the guidelines is that the rise should be allowed up to 30% from baseline, and the moment to reevaluate that is 4 weeks following the initiation of the treatment. And I think, and this is also something that is something that came up already in the diabetes management recommendations, and again here, that that you should really make an effort to continue those agents when indicated, and try to manage hyperkalemia, for instance, with clinical measures to allow the continuation of these medications due to the importance in terms of reduction of outcomes. In terms of mineralocorticoid receptor agonists, it is recognized the role in refractory hypertension, but again, especially for patients with very low GFR, we observed that the risk of hyperkalemia might be much higher and needs to be monitored and carefully managed. Finally, the assessment of the combination of therapies didn't add much to the previous guidelines, and we still felt that there was no basis for recommendation of a combination of ACEs and ARBs with DRI or even with an MRA, both in diabetes and non-diabetes patients. Okay, so this is the summary slide, and it just, highlights what we discussed over the last, 40 minutes. in terms of the important points of the guideline document. First of all, a big emphasis on the methodology for assessment of blood pressure. Second, an evidence-based approach to lifestyle with a focus on salt intake reduction and physical activity. And then a target for blood pressure based on a systolic, and preferential use of ACEs and ARBs. As I mentioned before, there is also in the document a section on pediatrics with interesting definitions, a review of the diagnosis of blood pressure in children and adolescents, and also an evidence review analysis of the use of ACEs and ARBs in that particular population. And also for transplant patients, you see here a unique target that is different from the general CKD population, and also recommendations regarding drugs that includes CCBs together with the ARB used in the transplanted population. So finally, I just wanted to leave you with this final message, which is, what are the potential implications of the guidelines that were just published? And I mean, right after publication, this paper came out. I think it's very interesting because it shows the size of the challenge that we have ahead of us. So a group of investigators actually looked at what the guideline is saying, and then it looked at some sources like the Ann Haynes examination survey, collected some of the data included in that population, and then came up with this unmet need that is clearly stated in this slide. First of all, in terms of blood pressure lowering in the initial bars here on the left, and you see here that if you apply the KDIGO 2021 guidelines, there is about 70% of patients with CKD who would be eligible for further blood pressure lowering. So the majority of patients in NHANES with CKD are not on target. And when it comes to eligibility for ACEs and ARBs, taking the revised guidelines, and you see how different it is from the previous guidelines with the extension of the recommendations for ACEs and ARBs, about 78% of patients would be eligible for RAS inhibition. So for you to have an idea, we recently analyzed this in CKDops and published that in the US, and this is nephrology run clinics, only 50% of patients with stages 4 and 5 are on ACEs and ARBs due to, most of the time, discontinuation over the course of the progression of kidney disease. So new guidelines, new methods, new technology involved, but the implementation is ahead of us, and the challenges are huge, as you can see here, and as you can probably perceive based on your own practice and clinical experience. So with that, I would like to thank for your attention, and I'll be happy to, take some questions in this last 5 minutes that we have.
Thank you so much, Roberto, for that overview of a tremendous amount of work that was done by the working group. These things are huge mountains of effort to climb. And I think we really appreciate the peek behind the curtain of kind of behind the scenes, how these things are developed, how the team came together, how the question was formed. We do have some time for some questions here, and I'll just go in the chat. We have 2 questions. I'll go with this one first. How much of the unmet need do you think falls into the categories of frailty, advanced CKD, where benefits of these targets are less clear?
Yeah, I think frailty would be really clustered in the more elderly population. And I think it all depends on where you live, right? I mean, I think there will be big geographic variations on how this is, how big the problem is. But I think frailty might represent a pretty large proportion of patients who would have low GFR and more advanced age. And I think this will just get worse in the future. So I think frailty is an issue. Of course, there are elderly patients who are, who are pretty fit and might be excluded from the analysis. But I think this will be a big problem in settings where the elderly population is more common. Now, a more advanced CKD is tricky, right? Because I mean, it is a big problem for us nephrologists, but I mean, the vast majority of patients with CKD, they are patients that fall under the category of, a GFR ranging from 30 to 45, or even more frequent in 45 to 60. So I think the biggest population that would be under the scope of this recommendations, I think that the vast majority of patients will not be patients with very advanced CKD. So I think the very advanced CKD that, where the evidence is not so high of some of the recommendations, I think they will be a big focus for nephrologists. But this guideline is actually should benefit people practicing with broader population groups. And I think in that way, I think most patients would be able to fit in the recommendations with higher degree of certainty that, they, first of all, they should be following that recommendation, but also that they should be safe to do it and they will tolerate it.
Thank you. And there's one more, and I think this is an interesting question and very practical. So we're in lockdown here in Ottawa, and many of the clinics have moved to virtual. So one of the questions we have is, given that patients are not coming into the clinics, how do these targets translate into home measures?
Yeah, I guess, Manish, the beauty of this was actually the fact that you could actually mimic the evaluation done in the RCTs, so I mean, if you look at Sprint, for instance, I mean, it is an office measurement. More specifically, it has a specific device, but we felt that it was not a good idea to recommend for a specific device just because of, the RCT data. But definitely the office measurement information was an important base for the recommendations. And I don't think that we know how this translates into a home measurement. Mm-hmm. I mean, common sense, I mean, you need to make decisions based on an unusual situation that we all live. But I think we need to be very clear that, the beauty of the recommendation of office measurement was really based on the possibility to really do something to classify, to diagnose, to classify patients. That was what was done in the trials that captured the outcomes that were reduced. So I think everything else would be uncertain in a way. Mm-hmm. But obviously, how many unusual decisions we've been making during the last year, right? So this is just one more.
Now, the last thing, I think, and I thank you, we're at time, but I'll just squeeze in one last thing because Dr. Haramath couldn't be here, but I'll represent him in spirit by asking, was there any discussion regarding the timing of the BP lowering medication, evening versus morning? Did this even enter the conversation? I know it's very controversial, but I just thought it would be interesting to hear what.
Oh yeah, I mean, there was a long discussion about this. There was a long discussion, and it's just I go back to the conceptual thing that I mentioned in the beginning of my conversation. KDIGO clearly stated to us working on that and asked the evidence review team to really capture the best, most robust information, and preferentially from RCT. And then when you put it into that level of data capture to come up with a recommendation about the timing was something we didn't feel that we could do. Basically because it is controversial, it's not very clear message based on RCTs. So unfortunately, I mean, you know, this could have been introduced as a practice point. That's the intention of practice points, is to measure that. And I can't recall why we actually decided not to include the timing as a practice point. Probably because there was a feeling that you know, there was no clear recommendations we wanted to give because of you know, how fragile the base data was.
Yeah, yeah, it's a very controversial area. Well, you know, I thank you. You know, we've gone a little over time, just a couple minutes, but I really just like to extend a thank you for virtually coming to visit us. And hopefully when the world is back to normal, we can have you visit in person. And terrific rounds. And I just like to thank you again for presenting to us today.
Thanks. It shouldn't take very long. It's a short drive from Ann Arbor to Ottawa. For American standards.
That's true.
All
Thanks
right.
again, everyone.
Okay. Bye, guys.